This video intends to demonstrate the technique of performing bilateral anterior cingulotomy using robotic guidance in a case of severe treatment refractory obsessive compulsive disorder. OCD is a common psychiatric condition characterized by intrusive thoughts, rituals, compulsive behavior which are recurrent and uncontrollable, leading to the distress and hampering patients' day-to-day activities. Briefly describing, there are multiple circuits involved in the disease process. However, two well-known cortico-striato-pallado-thalamocortical loops are implicated in the genesis of OCD. Namely, a direct pathway which is excitatory to the cortex, acting as a positive feedback, while the indirect pathway which finally leads to inhibitory response to the cortex is comparable to a negative feedback mechanism. These symptoms of OCD are strongly linked to the imbalance in the dopamine and serotonergic activity in the brain. It is postulated based on the imaging studies that hyperfunctioning of the dopaminergic activity in the orbitofrontal cortex and hypofunctioning of the serotonergic system in the basal ganglia to be responsible in the causation of the disease. A 23-year-old gentleman presented with history of obsessions and compulsions over a period of 11 years. He had intrusive thoughts of hands being dirty after touching anything, with a compulsive behavior of washing his hands frequently. Thoughts of wearing his clothes inside out, accompanied with a compulsive behavior of frequent changing of clothes. He also had thoughts of intrusive reading, leading to multiple reads and also multiple counting episodes. Due to these repetitive compulsive behavior, he was removed from the school and also could not retain his job. Examination revealed mild psychomotor slowing attributable to the polypharmacotherapy. A score of 36 was found on Weibuch scale, grouping the patient into the category of extreme obsessive compulsive disorder. This patient was managed initially with multiple selective serotonin reuptake inhibitors, which was followed by augmentation therapy over a period of 3 to 4 months without any benefit. He was subjected to 2 trials of cognitive behavioral therapy spanned over a period of 6 months, which included the OCD-specific exposure-response prevention therapy with only a transient improvement. Later on, 20 sessions of transcranial direct current stimulation was also tried, but with a limited success. Therefore, a diagnosis of treatment refractory OCD was made in view of failure of all the conservative treatment modalities as per the guidelines. This case was planned for bilateral anterior cingulotomies after obtaining the clearance from the Institutional Psychosurgery Board. Before proceeding to the planning and the surgery, we obtain MRI and CT brain in a specific imaging protocol, standardized for all the patients undergoing robotic guided surgery at our institution. The trajectory planning is done a day before surgery with the target point approximately 2 cm behind the tip of the frontal horn, 1 to 2 mm above the corpus callosum in the cingulate gyrus. Another trajectory on the same side is planned approximately 3 mm anterior to the first target point in the same plane. Symmetrical trajectories are planned on the contralateral side, making up a total of 4 trajectories. The trajectories are planned and checked meticulously so as to avoid transgressing any sulcus or vessels on the way to the target. The patient is positioned supine, head is fixed with a Mayfield clamp and attached to the robotic arm to achieve a rigid fixation. We routinely use skin-based laser registration, which begins initially with a 6-point facial registration. This is followed by the mesh registration covering the nose and the forehead region, followed by zigzag laser scanning of the forehead and then subsequently manual scanning of the bilateral temple regions. After the registration is complete, the accuracy of the registration is checked by pointing the laser to all the 6 points. The aim here is to attain a minimum error. If the error is more than 1 mm, then the points can be manually adjusted to correct it. In case of persistence of the error, re-registration should be done. The robotic arm is driven to the desired trajectory and the entry point is marked as per the laser pointer. The patient is draped as per the marked entry points. A 2.5 mm twist drill craniostomy is performed using a pneumatic powered handheld drill. This is followed by dural coagulation using a monopolar cautery. The distance to target is noted as per the robotic console. This length is marked on the radiofrequency coagulation probe using a scale. The important point to note here is not to move the robotic arm after the length is noted. We use the radiofrequency probe, which has a 4 mm long uninsulated active tip with a diameter of 2.2 mm. After inserting the probe to the desired length, an O-arm spin is performed for each of the first trajectories on either side. The O-arm CT is then merged with the pre-operative MRI images to see for the accuracy. Lesioning is performed after confirming the accuracy of the probe position. The lesion is created using 85 degrees centigrade for a period of 60 seconds, which approximately creates a lesion of 5 mm in diameter. Once this is done, the probe is then withdrawn by 3 mm and another lesion is created using the same parameters. Similar process is repeated with the rest of the other trajectories, thereby creating a total of 8 burns with 4 on each side. Prevention of the CSF leak is of utmost importance during withdrawal of the probe, which if unchecked can lead to brain shift and thereby significantly diminishing the accuracy of the burn lesion. This can be tackled by injecting the fibrin glue and thereby plugging the dural defect. Post-operative imaging shows good spherical lesions involving the bilateral cingulate gyri. Post-operative course was uneventful. Patient is more cheerful than previously and has joined back to his work. His Vibox score was 22 at 6 months and further reduced to 18 at 1 year follow-up compared to the pre-operative score of 36, quantifying an overall 50% improvement.